are seeing a big shift in decision-making from the federal government to the states with respect to Medicaid. And the current administration is a big proponent of this. And the repeal and replace bills in Congress this year would have dramatically restructured Medicaid so that the states would have, for example, maybe seen block grants instead of matching federal funds. Medicaid actually is the largest government program with over 70 million individuals, and by way of comparison, Medicare is about 55 million individuals. And the bills didn't pass Congress, but the administration nevertheless is using other tools at its disposal to accomplish really the same thing.
The administration has taken a number of steps already and has indicated that more are coming down the pike that will significantly impact the relationship that Medicaid, managed care plans, payors, and providers in the Medicaid program will be operating going forward. On the payer side, I think that the changes around reducing pathways to enrollment in the program, limiting benefits, and increasing sort of work requirements and things of that nature will reduce the number of people that are enrolling in the program and reduce the premium dollars going to a Medicaid managed care organization.
Providers may see an increase in emergency care and uncompensated care since there might be more uninsured. The payers will also see an impact from the shift in decision-making to the states because every state will have its own priorities in how they want to customize their Medicaid program, and the payers will have to implement each state's customized program, if you will. And there's a saying in Medicaid, if you've seen one Medicaid program, you've seen one Medicaid program.
I think the one outlier that I would want to highlight is especially addiction treatment providers. The administration has continued and actually furthered the efforts of the Obama administration in trying to increase access to especially residential addiction treatment by just this last week releasing additional guidance for states on implementing 1115 waivers for their substance use disorder systems, which could, for especially residential addiction treatment providers that have historically been excluded from Medicaid under the IMD exclusion, will be able to have access to Medicaid dollars for the first time in more states than were allowed under the Obama administration.
We're seeing a big shift towards value-based payment in Medicaid in the states and towards providers taking risk, having more skin in the game so that perhaps quality would improve and there'd be more care management and hopefully costs would decrease. And along that continuum, value-based payment could mean anything from a bonus based on meeting quality metrics to shared savings if costs go down, or shared risk if costs go up, or taking full risk from the plan for an entire population's health care. And many providers aren't used to taking on that kind of risk.
As we move towards value, we are increasingly moving towards clinical integration. And clinical integration requires providers that are otherwise working individually to work collectively. And that implicates antitrust laws. It also implicates Stark, anti-kickback. And so there is a need for a wholesale shift in the regulatory environment.
The sort of broader systemic changes in the use of value-based payment in the Medicaid program are likely to continue. The Trump administration has made it clear over the last couple of weeks that they will continue to support delivery system reform initiatives at the state level, and in fact will make it easier for states to get approval and have less oversight and regulatory burdens in imposing those. That has significant implications for provider entities that are participating in these initiatives, and it varies a lot by state.
Additionally, licensure laws may come into play. If providers taking full risk, many times they'll also do utilization review and claims payment, and a lot of states have licensure requirements for those. And the contract terms really for the most sophisticated value-based payment arrangements need to be very clear. So you need to understand the provider's role, the payer's role needs to be spelled out clearly, the financial terms, even using examples because they can get very complicated.
The healthcare system has been in a great divide. Behavioral health was on one side, physical health was on the other. Today, as I many times say, we've now recognized that the head is actually connected to the body, and it's all one system. What I'm saying is that behavioral health and physical health are really connected. And because of value-based focus, we're now beginning to bring those two issues together. And because there is a number of prohibitions in sharing mental health information, this is an area where we're seeing a lot of legal activity.
For payers, I think that they really need to be maintaining really good relationships with their state regulators, both on the insurance department side as well as in the Medicaid side of state operations. Because that relationship, both through the contract management and procurement process, but also in the regulation of these new programs, is going to be crucial in determining whether not only they're successful, but whether they can even participate at all.
When a provider's taking any downside risk in a value-based payment arrangement, there are specific protections that should be considered. For example, stop-loss insurance or reinsurance, outliers, risk corridors, another type of protection, and they can be negotiated in most arrangements, and Medicaid providers should consider those if they're taking downside risk.
Payers and providers do need to adapt, and I think that there are several things they can do. I'd say first is change their planning horizon so that long-term planning is more a year or two as opposed to 5 years. The environment has gotten so dynamic and so competitive that both payers and providers need to look at their planning horizon in a much shorter space.